thanking both Ebba and Donnie for their warm welcome, and to all of you here in Stockholm for inviting us and this great dialogue we've had over the past day. So it's really a privilege to be on this stage talking about work that many people are doing around the world, really changing lives, leveraging modern technology that's now becoming more and more ubiquitous. We talk about disruptive technology, but it's also important to think about leapfrogging technology, how innovations that have happened in the technology ecosystem are enabling our healthcare delivery systems to be more effective despite the fact that we haven't made those investments from the health sector, but they're really coming from the technology sector. So I was trained in infectious disease epidemiology, and this is how we were trained to see the world. Here you see the countries of the earth inflated by the relative proportion of disease and death which those countries suffer from. And what you see is the justification why I spend most of my time in Sub-Saharan Africa and South Asia, because that's really where the chief burden of death and disease are being experienced by mothers and children in the developing world. But just to give you a sense of the urgency that we act now, this is a picture that I always like to include when I talk to audiences about MHealth, because this is why I do what I do when I get up in the morning. Each week, every 2 weeks in South Asia, and sometimes every week in countries like Afghanistan and India, you're looking at a Boeing 747 filled to the brim with new mothers and pregnant women crashing. And if that doesn't sort of drive home the urgency that we find a solution that incorporates all the different strategies that we have at our hands, from vaccines to mobile phones, then we really do a disservice to these people. But there is a global revolution happening, and this is another way to see the world. This is a Euclidean map of only a fraction of the Facebook users around the world. And you can see where, in the absence of any political boundaries, the entire globe coming to life in front of your eyes, from Sub-Saharan Africa to South Asia, entire countries being lit up simply with Facebook connections, a technology that 5, 6, 7 years ago, in most of these countries, you wouldn't even have had a recognition of what the word Facebook means. And this is why, ladies and gentlemen, we're looking today at a situation where there are nearly as many mobile phone connections on this planet as there are human beings. And that is a reality that we need to leverage as we think about ways to deliver better and more effective care in these low-resource settings. When I went to work in rural Bangladesh as a project scientist for a large maternal health project in 2001, I kid you not, I put out a tender to purchase 50 of these little things, because this was the only way we could communicate 50 kilometers apart between two of our project sites. Carrier pigeons was the most serious thing in 2001 that I had as an option to communicate. But then our friends from Nokia partnered up with Telenor and began to change the way we did communications in this typical South Asian country. When I left in 2008 to return back to Baltimore, we had faster 3G internet connectivity in rural Bangladesh than we did in urban Baltimore. So the reality of the infrastructure in some of these low-resource settings is something quite phenomenal. Today, our field staff of over 850 community health workers almost have 100% own phone ownership. These families have their own personal phones and are able to communicate in a landscape where 80% of families still give birth in the home. So think of that reality, ladies and gentlemen. We did a survey a few years ago to look at how people were using MHealth in the wild. How were mobile phones being used in the absence of any formal MHealth strategy? And we found that people who were experiencing serious crises in pregnancy, in this case, about 611 women said that they nearly died during their pregnancy. Half of those women, back in 2011, were using the mobile phone to do a number of things that were critical to saving their lives during that crisis period. In, again, rural Bangladesh, a typical population of the greater Gangetic floodplain. Just a few years ago, we did a survey of almost 170,000 women in this community, 71% owned their own phone at this point. But I think for me, the more exciting statistic here is the last one, where 71% of these women owned phones, with only 23% of them having electricity in their homes. So when we sit in a boardroom in Washington, D.C. or in Seattle and we scratch our heads and say, how can we be talking about MHealth solutions for the developing world when there's not even electricity? But they have figured out solutions. There are battery exchange programs. There are solar panels that you can use to charge your phone for a few pennies or cents, depending on which village you find yourself in. And that's unleashed this global dialogue that we now have about MHealth. This untethered but yet connected reality of healthcare, where we're able to improve the delivery of care and really target doing what we know works, getting those solutions to the level of coverage that is necessary to save lives in these communities. There have been a proliferation of MHealth innovations around the world. You heard about some of these yesterday, but one criticism that we often hear is that there are more pilots in the MHealth space than there are in the US Air Force. But what that means is that people are really coming to terms with the reality that this technology does represent a potential way to leapfrog over those barriers that have prevented us from delivering care in these hard-to-reach populations. At Johns Hopkins alone, we have over 130 faculty working on MHealth strategies, both for clinical care in the US, but also for care in low-resource settings, from Uganda all the way to Burma. But it's important to keep in mind that MHealth is not one thing. When somebody tells you today that they're working on MHealth, push them a little further, because your MHealth may not be the same thing as my MHealth. There's a diversity of applications, from using MHealth to educate clients, to educate providers, all the way to managing drug supply chains in these low-resource, hard-to-reach populations. There's an ecosystem of tools that have been developed, but really integrating this mobile environment. None of us have gone out and bought a mobile phone just for the purposes of healthcare. We've bought this phone because it gives us access to products. It gives us access to information. And I think it's important for us to be thinking about the ecosystem, of which you see a snapshot here. From politics to healthcare to financing to agriculture, the mobile phone is transforming the landscape of development in the low-resource world. As we think about ways to understand this ecosystem, it's important to think about 3 layers of strategies that are used to target MHealth towards improving healthcare. These are the layers of patient, provider, and system. For patients, it's about access to information. Sending text messages to remind patients to take their medication has been one of the most effective ways in which we've been able to use mobile tools to improve adherence to important drugs like antiretrovirals for people with HIV. Providers, giving clinicians access to decision support tools, making sure that they are providing the best level of care that they can be providing in that particular context. But things like supply chain management. Imagine being in rural Zambia. Your child has malaria, and you go to the local clinic, but they've run out of anti-malarial drugs. And you have to wait a week to 2 weeks for those drugs to come into that clinic. But with mobile phone strategies now, we're able to alert the central supply station when those drugs are reaching a critical threshold, being able to replenish them in time, preventing that critical stockout. It's important also to note that MHealth does not work in a vacuum. You cannot see MHealth as a magic bullet. It's important to realize that this solution is part of an entire ecosystem, making sure that the transportation schemes are available, that staff is trained and accessible in the facilities that are functional and equipped. And finally, the data utilization. Yesterday I saw a tweet where someone was saying, it's great to talk about big data, but we're not talking about using that data. And I think that's the same for the developed world as it is for the developing world as well. The other thing that we also know is that over the past 2 decades, public health scientists have discovered hundreds of ways to improve life and to save lives across first-level, community-level interventions, all the way to tertiary care facilities in the hospitals. The question for us is taking these strategies and getting them to those women and children giving birth in rural communities from Zambia to rural Nepal. How can we get these frontline healthcare providers to know what to do, when to do those things, and how to deliver the level of care that they can deliver, and when should they refer those patients for further care, is something that continues to be challenging to the communities. So we've really tried to shift the dialogue in global health about MHealth not being a magic bullet, but for taking interventions of known efficacy, what we know works, breastfeeding, vaccines, preventing hypothermia shortly after birth, and reaching those levels of coverage that are plagued by these many potholes, poor demand for services, drug stockouts. MHealth we see as a solution to bridge those potholes as we try to take what we know works and shift them into the high degrees of coverage that WHO, UNICEF, and other global health agencies have been striving to achieve. So it's not about what can we do that's new with MHealth, but how do we use MHealth to optimize what we already know works? So some examples. MAMA is a program that the US government and Johnson & Johnson and a number of other agencies have partnered with in-country governments in India, in Bangladesh, in Russia, and South Africa to send pregnant women messages about healthy pregnancy, diet, care of the newborn at the appropriate time in their gestation on their mobile phones. And this is now being evaluated in a number of sites around the world to really measure the impact it's having on improving health outcomes. SMS for Life is a program that Novartis and a number of other companies have done in Sub-Saharan Africa, again, sending simple text messages on a daily basis to count the amount of essential drug and other commodities that are available in rural health pharmacies. So as you see here, the pharmacist is sending a text message saying, I have 3 bottles of drug 1, 2 bottles of drug 2, and what that does is trigger a supply chain response based on those critical thresholds. In places like Nigeria, drug falsification is a major problem. It's not just a problem for the pharma industry, but it's also costing a lot of lives. Because when you have a deathly illness like malaria and you're taking placebos because that's what you bought on the market, it can cost you your life. Well, here they've introduced a way to send a text message with a unique serial number that allows you to verify whether that drug is in fact authentic or falsified. But then we talk about task shifting. When the ratio of human resources to patients is so disproportionate, how can we empower minimally trained frontline health workers to do some of the jobs that are more difficult using this technology? So our partners at Stanford University have just added a simple adapter to a camera-enabled smartphone to take photographs of the inside of the buccal surface to look for precancerous lesions. And as you know, in much of South Asia, where people chew betel nut and tobacco, oral cancer is a leading cause of death for individuals in this age group. UNICEF is using child count to track the growth of children during those critical years of life when it's important to identify children who are growing poorly or failing to thrive. By entering their upper arm circumference into a text message, the phone is able to check with a server and alert the worker that this child is failing to grow, that it needs more urgent nutritional intervention to ensure that it's on track for its proper growth. But then some folks are also working on integrating a lot of these solutions that you saw yesterday, technologies that are on display outside for the developed world, are also being shifted to provide backpack clinics for workers in places like rural India. Here you see everything from heart rate, body temperature, EKG, all being run by a solar panel in a backpack that's now being pioneered by the Public Health Foundation of India. We're working with the government in rural Bangladesh to deliver this kind of integrated, holistic solution, starting with simple activities like pregnancy registration, going through a community and making sure women are registered so that we can deliver the right drugs and services to those women during their routine pregnancy, but also mobilizing those referral networks when it's necessary during a pregnancy crisis. We just worked with the FDA to test one of these devices, a portable mobile ultrasound, where we can now look at pregnancy status in the field, in rural villages, using a simple ultrasound attachment attached to a smartphone. Mobile microscopy. We have colleagues at UCLA developing ways that you can use a mobile phone to look for malaria parasites in a blood smear, shifting the time that it takes to identify a malaria case from weeks to merely hours. One thing, I just got back from Bangladesh a few weeks ago, and I was looking at what technologies were new in this market. And one of these children in the village came up to me and showed me, "Sir, look, we're using these micro SD cards." I said, I just got my first micro SD card a year ago, and you're already selling these in rural Bangladesh for less than 50 kroner. A 16 gigabyte micro SD card, and they're showing these kinds of videos, but we're now thinking about leveraging this for health communication in these rural populations. But in places like Sub-Saharan Africa and South Asia, mobile money is also a valuable thing that can be leveraged into health to improve the way we deliver care, compensating women for coming in for care, allowing them to have those resources they need when they need them. But also there are more sophisticated things coming online. We're working with a group to develop flow cytometry, being able to do complete blood counts at the point of care in these village settings. For those of you who are interested, I have one of these here in my pocket that allows you to take a FDA-approved ECG on your smartphone from anywhere in the world and send that to a cardiac specialist for further analysis. With WHO, we've been working to help move this innovation into application. And so the MHealth Technical Evidence Review Group was formed a few years ago to help look at the state of evidence and where do we have sufficient information to move from pilot into practice. And this has been a really important innovation. Defining, is your MHealth the same as my MHealth? What do we know, at what cost, and at what evidence point to implement in these low-resource settings? We published a framework last year that I can also share with you that many companies and groups are using to help explain MHealth in a much more technology-neutral way. And so these 12 building blocks of MHealth are increasingly being used as a way of defining and describing what it is that MHealth solutions do. Think of these as the ingredients that you're putting into your soup in order to create an effective solution in this setting. So if this quick summary of the global landscape has stimulated some neurons, what I'll ask you to do is go to mhealthevidence.org or mhealthknowledge.org and read up more on what the state of the art is. And I think you'll find a lot of exciting stuff that's going on all over the world in this innovation space. We also recently launched Registry.org to be able to allow projects and innovators like yourselves to register their projects with the World Health Organization so that we, instead of duplicating each other's efforts, we synergize with each other to make sure we have an added advantage in the space. I'll close with two final thoughts. And that is, we often are impatient optimists, as our friend Bill Gates likes to say. We want to see change happen quickly. But in global health, it's often like this little girl trying to push the elephant up into the truck. And as a scientist, I always like to make a chart out of everything. So you have to think about the degree that your innovation is disruptive to the system, to the status quo. You can expect there to be a complexity of the ecosystem that you're trying to change, difficulty in making that change happen, and institutional inertia. So it's not surprising if it takes you longer than you need to actually see that change happen. Be patient, and you will see this change being embraced gradually. We want to be careful not to go from this reality to this reality. And as our friend here says, more data does not mean better information. And so with that, I leave you with the final thought that we should draw inspiration from Botswana and Bangladesh to Brussels and Baltimore, because I think there's a lot of cross-pollination that we can see happening from the innovation that's happening in the low-resource parts of the world to inform how we do things in places like Stockholm. So with that, I'd like to thank all of you and challenge you to dream of what may be possible. Thank you very much.
Thank you so much.